Thank you so much, and we thank you for Professor Pastor and you actually can discuss that. So without further delay, maybe we shall start our ACNS special YNS member. So today, shall I invite? So maybe this time, shall I invite Dr. Hui to give the introduction and introduction of our chair and the speakers. Dr. Hui is also one of the active ACNS YNS member and his lead man. So maybe this time he could take the lead for this special ACNS YNS research webinar today. Please, Dr. Hui.
Hello, honored professors and colleagues. My name is Huy Pham from Vietnam, and welcome everyone to ACNS Young Neurosurgeon Conference special research webinar. And today's webinar is hosted by Professor 𝒓𝒂𝒂𝒊, who is the president of Asian Congress of Neurological Surgeons. The chair of our webinar today is Professor Athun Ngoyen, who is from Department of Neurosurgery at King Edward Memorial Hospital and State Medical College. He's also the chief neurosurgeon at Tata Memorial Hospital and Cancer Research Institute in Mumbai, India. And the primary discussion today is Professor Ansra Anfauzi from the Neurovascular and Neuroendovascular Therapy Center at Department of Neurosurgery at the Universidad Airlangga and Dr. Sutomo General Academic Hospital in Indonesia. There are 5 speakers today. Professor Mohan Sama from the Department of Neurosurgery at Chikrupan University Teaching Hospital in Kathmandu, Nepal. And Professor Eckhard Kasper, who is the professor at the Department of Neurosurgery at Boston University, Tubanian, FBC School of Medicine in Boston, USA. Dr. Professor Gleb Danilov, who is the scientific secretary and also head of laboratory of biomedical and informatics and artificial intelligence and the Burdenko Neurosurgical Center in Moscow, Russia. Professor Shunsuke Nakaya from the Department of Neurosurgery at Fujita Health University Hospital, Nagoya, Japan. And Professor Itichai Takarunchai from the Department of Neurosurgery at Brain and Cerebrovascular Center, King Taksin Memorial Hospital in Bangkok, Thailand. In moderation with me today, and there are also Dr. Ban from Hong Kong, Dr. Zoe Assam from Malaysia, Dr. Sanawat Biswat from Bangladesh, and Dr. Atik Islam from Bangladesh as well. Firstly, to start the webinar, I would like to invite Professor 𝒓𝒂𝒂𝒊 to have a few words to open the webinar.
So everyone is very welcome. So we are very much looking for your research work today, I think. So let's start.
So now I would like to invite Professor Athun Ngoyen to chair the webinar.
Thank you very much, and I'm looking forward to enjoying my Sunday with some fantastic academic work, and let us see how we learn and how we progress and how we can influence the young people of Asia. And my best wishes to you. Just please continue the first lecture, Mohan Sharma. Please invite. Can you invite Dr. Mohan Sharma?
Yeah, thank you. I am here.
Okay, okay, Mohan. So I look forward to hearing you.
Thank you, sir. So thank you for the opportunity to be in this webinar. Let me share my screen. Is my screen visible, Dr. Goel?
Yes, very much. Beautiful.
Thank you so much. This is such a really privilege and honor for me to be speaking in this webinar. And the topic I have chosen for today is why we as neurosurgeons should also be researchers. I bring warm greetings to you from snow-capped mountains and the rhododendron, which is very popular and very fluorescent in Nepal. And this is the hospital in Kathmandu where I work. It is an 800-bedded multi-specialty hospital with a dedicated neurosurgery department with a residency program. This is my disclaimer in this presentation. It takes considerable knowledge just to realize the extent of your own ignorance. I learned that to be a good neurosurgeon, you should also be a good researcher in quite later part of my career. So this is my ignorance, and I still learning this regard. So this is the general question I'd like to start my presentation with. Does doing research make you rich and famous? This everybody knows who this guy is, and everybody knows who this woman is. But very few people might know who this gentleman is. He is based on this data ranking wave of universities in 2022, Professor Kessler is the one with the highest number of citations. Maybe somebody has beaten this record, but not many people know him. So this is one of the reasons that, technically you will not be that famous or rich by doing research, but still you need to do. Another question I have for all of you is, does supervising your resident make you rich and famous? This is Professor Sean Wu, a professor at both University of Michigan and University of Wisconsin. He holds the record of supervising 113 PhD students, highest number till date. And this is another Professor Julian Swinger, the Nobel laureate in physics at Harvard, and he has the record of supervising 75 PhDs, and 4 of them went on to win the Nobel Prize. But they are not necessarily famous, but you have to do some work to advance your science forward. And this I borrowed from Dr. Grootenius from Netherlands. What happens when we all concentrate only on the OR and seeing clinic and not participating in research? We will become better and better in those surgeries that we perform more often. Patients and OR staffs will admire you for your great surgical skill. Probably you will earn more money, and you tend to impress your colleagues/enemies. The better you become, you will definitely earn some enemies. So these are all seem positive effect. Then, but it isn't great, because we will be nothing more than good craftsmen rather than a scientist. And we will need other people with knowledge to tell us what we should do. And third, we will only be a knowledge consumer and not a knowledge producer, which is not a good thing to be if we claim that we are a really good clinical scientists. So this is the reason we need to be involved in research. Otherwise, we'll go back to the barber surgeon period. This Dr. Robert Liston, he has the record of doing the lower leg amputation in 2.5 minutes, supposed to be the fastest knife. But this is not the way the modern neurosurgeon should practice. You would be a perfect craftsman, but not the scientist. So with this background, I'd like to delve into the basic concept of research. So this is the way we learn new knowledge. First and foremost is the experience, but the disadvantage of experience is your life is too short to learn everything by experience. And next is reasoning or logic, and the logic also is slow, but the next and the most scientific way of acquiring new knowledge is by conducting research. Obviously, research has 2 components. First is the systematic investigation of the thing, which involves some methods applied in the process, and the next aspect is the thing has to be generalizable. Whenever you do a research, then the results of the research should be generalizable beyond the sample population. So rationale for conducting research, this is really old data, 1990, but it still holds true. The doing research is the most scientific method to understand the epidemiology of disease, determine the utility and applicability of the diagnostic test, best select the best treatment modalities, and develop new tools and methodologies to measure and promote health equity. So these are the reasons we need to do research by ourselves. Now, another argument is, why should we do research in developing countries when there is ample research done in high-income countries? regions are these. Strengthening research capacity in developing country with a different geography and culture is one of the most effective and sustainable ways of advancing health and development in this country. This was the 1090 report on health research by Global Forum for Health Research. Another specific reason is good quality research is central to the health system strengthening in any country. And the results of the research in high-income countries may not be generalizable to developing countries for obvious reason, because they have got different genetic makeup, they have got different, way of responding to the disease. This is another reason. And despite being home to over 80% of the world population, developing countries are hugely underrepresented in the world literature. This is also another fact that we need to overcome. But this is the paradox here. Definition in developing country, definition of research in developing countries like this. This is a ketchup which fits in with every kind of dishes you make. So many hospitals in developing countries, they write their name as this hospital and research center. Hardly any research is done there. So this is the, this is the problem with us. Now I take you through why neurosurgeons do the research. I'll quote from this journal, World Journal of Orthopedics. So they have written this editorial as research in spine surgery. If spine surgeons do not want poor quality research to dictate and limit their clinical decision, then the responsibility rests with these practitioners to design high quality study to justify certain treatment modalities. You cannot make decision based on the research done somewhere else. You have to do it by yourselves. This will be the argument. And why we should be doing, clinicians should be at the forefront, clinical scientists, because we have the first-hand access to the patient. Not that you misutilize the access to your advantage, but at least you have the access where you can do the research. There has been some triggers for accelerated growth of research in developing country last 20 years or so. These are mainly with the advent of fourth industrial revolution. There has been rapid advances in travel, the internet, and social media platforms. And increasingly, it has become easier to identify the research gaps and arrange international collaboration and logistics. And the biggest trigger is the COVID-19 pandemic that breached the geographical boundaries and making research dissemination much easier than ever. So this was the publication, little old publication, 2013, but it shows the status of clinical trials in Asia. So these are the countries where clinical studies have been performed from 2001 to 2012. And India and Thailand were the most highly, active countries where the clinical studies were performed. And next slide shows the top 10 countries with the clinical trial, top 10 leading countries in East Asia, South Asia, and Southeast Asia from 2001 to 12. Here also India, Republic of Korea, Taiwan, and China leading the front. Nepal is still not represented here, but we'll work hard to make sure that next similar paper will be represented here as well. So a couple of slides regarding the neurosurgical publication in Nepal. Look at this from 1999 to 2024. There has been sharp increase in the number of publications from Nepal as well. And from 2018 to 2094, it has really gone up. Thanks to the COVID-19 pandemic, always some positive side effect. And this is the paper we published last year in Brain and Spine, Academic Neurosurgery in Nepal. And this shows the trend of publication of article in PubMed Index journal by Nepalese neurosurgeon. And if you look at from 2001 to 2022, there has been steady growth of the number of publications from Nepal. So I think Nepal is one of the country that can be extrapolated as a low and middle income country, and it might represent the similar trend of other countries too. So what are the barriers and the potential solution for increasing the research in developing countries? One argument is the insufficient research capacity. Yes, there is some research capacity insufficient compared to some big institute, but they are not that bad also. Every medical college is supposed to have a research center or department. So if we do that, then we'll be able to address. And inadequate research enthusiasm, in my opinion, is the main culprit why we have not been able to, able to pump more research paper from our side. So further, to address the inadequate research enthusiasm, we have to incorporate research methodology courses in the undergraduate as well as postgraduate programs. So they will be more interested in research and publication. And another is we need to have encouragement and mentorship by the senior, faculty, so that the junior will be interested to conduct this. And another important thing, in my opinion, is we have to incentivize the research performed. If research is considered something extra and it doesn't give you any incentive, people immediately lose interest, especially the clinician. So it could be in the form of offering more job opportunities or higher salary or faster career advancement, or some scholarship to participate in conference. It could be in many forms that will encourage young colleagues to be involved in research. Lack of expertise used to be the main reason until 2 decades ago. Now in every country there are some people who are interested and have some expertise in research. So you have to to address this lack of expertise. Training courses, multilateral collaboration will help, and sometimes you can ensure that short-term visit to the International Research Center is done, or you can invite international experts who are involved in research to train the local scientists. This is how we can address this. And lack of funding, lack of funding is never an issue for me, in my opinion. There is always some way you can get your research done, both nationally and internationally. Many organizations offer fund, but it's the question of knowing where to apply and how to get it done. Another way is to get the collaboration. Third and most important, the last one and most important in my opinion, is the brain drain. Whoever is expert tend to leave the country, especially Asia and Africa. That is the problem. And how to retain these, the brain is an issue for the policymaker. But you can help by developing adequate infrastructure at home, or providing protected research time for this, and some degree of financial security. There was an article, why America is poaching doctors from the Asia. It was a beautiful article in, I think, New York Times, and one of the reason is the financial stability is one of the most one of the reason why doctors leave developing country and migrate to rich country. Dissemination of the research work. This was the WHO bulletin, and it says, why is research from developing country underrepresented? And this was a BMJ open paper which has analyzed what are the reasons why these are underrepresented. And this is the reason, I think, why we are so underrepresented. Not that we have not done any research. Dissemination of research carried out in developing countries is vital, as said earlier, but the reasons are hard to get published in the mainstream journal. The reasons are this, small scale research cannot compete with other more rigorous research in the high impact journal factor. And another is the suboptimal scientific writing skill. This is the area where we can make an impact doing paper writing courses. And another is high publication cost in mainstream international journal. Thanks to Professor Kato and Asian Congress of Neurological Surgeon, where they have got open access PubMed index journal, Asian Journal of Neurosurgery. But other high-end journal usually charge money, and then this could be a barrier. Another is, senior members with international exposure can guide the younger colleagues to disseminate this and focus more on the quality rather than quantity. We have seen younger colleagues to be the paper mill. Every day you do not need to have one paper out. There will be some compromise. You should concentrate on having a good quality rather than quantity of the journal. And it is wrong to launch a new journal without a significant pool of good quality articles. I have seen that happen in Nepal. Too many journals are there competing with for a good quality articles, and which doesn't serve any purpose. Your journal's standard will never go high. That's another reason. And the periodic scientific writing workshop is the way to go to address this issue. So just one, this is same, I would say this is shameless advertisement. This is my YouTube channel, and this is how I want to disseminate the research related content, which I upload almost every week and to my younger colleagues. So to conclude my presentation for today, we need to, senior member of the society should do something related to research so that the younger generation will be inspired. This I took from Susutra, who is the ancient surgeon of Hindu philosophy. What he said is through continuity survives. He is the one who first started the pedicle flap for the rhinoplasty, and he suggested to have a pedicle with a artery so that the flap will no longer be dead. Same thing with us, the senior member of the society, if they do not transmit the research knowledge to the younger generation, then the flap will not survive. Thank you so much for your attention. This is my concluding slide. Thank you, Professor Goel.
Thank you, Mohan. That was a wonderful presentation. What we must also realize, as you rightly said, there are limitations of writing, limitations of doing research, and limitations of various kinds of activities. There are limitations in our, but also we must realize that we have some advantages, that our patient volume is very big. We can work on more patients. Our complexity of cases is very big. So we have some advantages, and we should use those advantages to write our experience. And I have, to an extent, felt that what we can contribute from relatively poorer countries is our experience with cases, because we don't lack now technology too much, and not too much technology in any case required for neurosurgery. We have the patient volume, and we should showcase our work through our volumes and our complexity. All in all, Mohan, that was a very fantastic. Many young people will be encouraged, and thank you very much.
Thank you, sir. Thank you.
Can I add one line? I loved your talk, Mohan. I think it's beautiful to invite everyone to participate in research, because it elevates the entire department. It makes your thinking critical. It makes you multidisciplinary. No matter where you live, nobody can prevent you from reading. Reading is the first thing you need to do to understand where's the knowledge gap. What is out there? What do we know? What is rare? What is frequent? And yes, maybe you can't compete with a high technology lab in Harvard or in the UK, but you can always contribute in a smart, astute observation. And you can start with rare diseases, writing your experience, how to manage very advanced disease or manage the same disease with limited resources. And I think there's a huge value in contributing smaller series to the literature of well-managed patients, and therefore you don't need to compete with the big institutions that have big registries. So don't be shy in starting with a good observation, read about it, and then smart writing will open any door. And with the help of some guidance from senior surgeons around this platform or other WFNS institutions, you will get out there and get your word out and your name out.
Thank you so much for your kind words.
Hello, can I say a word?
Yes, yes, please, of course.
Thank you very much. Excellent talk. Fantastic. Well done. And I agree with my colleagues who have just spoken. It's very important to do the research. Basically, it's answering one question is why are we having this problem? And once you know the why, then you can act on it and correct a problem. The only thing I wanted to add is that I believe we shouldn't put together the fact that for you to do research, you need to have a lot of money. That's, I think, completely wrong. There are a lot of discoveries which were done on corners of the world where there was almost nothing, and they managed. So the most important thing is the mind, which is looking for the problem, the connection of this problem with the environment or whatever, food or whatever, how we can correct it. It's very, very important. So the fact that you don't have doesn't mean that you cannot contribute to the world science. Okay, I'll just give you an example. We contributed to how to avoid infection when you put a VP shunt. This is a simple operation, but the complications in terms of infection are quite high. We found that it was just easy by chance, because we were looking for that solution. We found that by just changing the way we work, using isobetadine on a regular basis, basically working on the wet kind of environment, we managed to prevent a lot of infections. It's not something which you're going to earn, a Nobel Prize, but it definitely solved our problem of infection in that particular case. So that can be applied in a lot of pathologies. Thank you very much.
Ben?
Yes, and thank you so much. And I totally agree with what Professor Mohan and Professor Casper's comments. And I think for us as a young neurosurgeon, besides we fulfill our clinical duty to such a practice and research in an inevitable part of our training, and we should, in order to improve our department, we should encourage ourselves or our colleagues to push forward. So one of the questions I would like to ask Professor Mohan about. So in developing countries, and I know there are so many trials that you could start on and start publishing, but how about for the very junior colleagues in your department? So how could you encourage them to take more initiatives in the research? So what's your
thank you. Thank you for the question. We encourage them to start with a simple case report. Somebody who is really novice, they start with a simple case report and do the observational study. So retrospective case series, anything. We have, as Professor Goel said, we have a huge volume. We can write on anything, but they need inspiration. So next, I encourage them is to write on retrospective case series. And then our residency has a mandatory thesis writing project. We have a 3-year residency project. So they have to prospectively recruit the patient and write a thesis. And we encourage our resident to publish that also. So by the end of their residency, they will have at least 4 or 5 papers. So this is how we do. Another is we have a small, $800 encouragement kind of, scholarship that we can get from our campus for the resident and for the department. That also helps. It's around $800 per year.
I see. Thank you very much. And this is very important to us. And we as ACNS, we also encourage research, and we have our own paper, the Asian Journal of Neurosurgery, and we do encourage more publications from the site and more brilliant research, so that we could support research activities among the young neurosurgeon. And thank you so much.
Yoko, can I make one suggestion? My suggestion is that for Yoko, are you listening?
Yes, I'm listening.
You know what? As a part of ACNS activity, we can give some award to the, a young neurosurgeon from our Asian territory. If he has written some nice article or he has done some good contribution, we can give some award to ACNS.
Yeah.
I think that may be one activity that we can start and we can encourage young people, if you think it is correct.
Oh, that's great. Great idea. Thanks so much. So maybe Dr. Howard?
Hello, greeting. Konnichiwa, Assalamu alaikum.
Konnichiwa.
I'm Dr. Prizat from Afghanistan. Thank you, Professor Mohan Sharma. A great presentation. Thank you very much. And developing countries, two more things are also challenging the developing country like Afghanistan. This first is research center. We have a research center. No, and so sorry about that. And the other thing is no investments, no private and no government, public investment in developing country research. It's also a challenge for us, unfortunately, and still we use countries research results, and different from to country from people for thank you very much. And we would like to also support developing countries for making research centers and some training for research. It is very important. Thank you.
Okay. So, Dr. Hui? Thank you very much, Dr. Mohan. So it was a great talk. I think in Nepal, I know for many years, but by effort, I think it's getting more and more promote to encourage the YNS to write a paper. Thank you so much. Okay.
Thank you, Professor Mohan Sharma, for the presentation. Maybe we can move to the next presentation. It should be noted that this presentation should last within 15 minutes for the second time. So the next presentation will be from Professor Eckhard Casper from the USA.
Okay, let me see that I can share my screen. Give me a moment. Can you guys see my screen?
Yeah.
Maybe I need to go into presentation mode. 1 second, slideshow. All right, can you see my screen?
Yes.
Yes.
Wonderful. So thank you, Yoko, to have me invited with all your team to contribute to today's meeting with a small clinical talk that I want to use as another example how you can do clinical research based on your day-to-day patient encounters. And just as my previous speakers and Kazadi had said, you can start clinical research by observing well from your daily practice. And as Mohan said, start with the case report of a rare disease, of an unusual technical observation you've made, and put it out there as your first step to contribute to the literature. So instead of talking about a frequent topic, which is arachnoidal cysts in the supratentorial compartment, I thought I limit myself to P. fossa arachnoidal cysts. I want to show you some rare observations and a good idea that we had how to tackle this. And one of my international fellows is writing this up. So I have nothing to disclose other than the institutions I work in and some collaborations in the various societies. Today we want to talk about arachnoid cysts, basically a general introduction, some epidemiology and background. I want to take you through anatomy and classifications, and then I want to take you through some clinical presentations and treatment indications with some strategies. And I give you 2 or 3 surgical scenarios how to treat such cysts in a rare location. So first of all, what are arachnoid cysts? Well, they have been described many years ago as usually done in autopsy in the 1800s in London as congenital fluid-filled compartments within the CSF cisterns, and they basically have a border by arachnoid membrane, and they contain some form of clear colorless fluid that is similar to actual CSF. The cyst wall resembles normal arachnoid membrane, but has thick collagen and some hyperplastic cells in it. So it's not just subarachnoid space, it's a compartment. And the surprising observation then was it's notably devoid of any connection to the ventricular system. These arachnoid cysts are known to develop from alterations in CSF flow during the early phase of subarachnoid space and sac formation, leading to some form of splitting of arachnoid membranes. Morphologically, we can classify them by location into supratentorial, infratentorial, and mixed arachnoid cysts. And for today's purpose, we just want to talk about infratentorial mixed. Arachnoid cysts account only for 1% of intracranial mass lesions. So you may ask, why do you deal with this? Well, it's a real issue out there. It happens in everyone's tumor practice, and patients come with the same questions they come if they have a brain tumor because they don't know what the mass is that is inside the head. For the PFOSA, Little categorized these infratentorial arachnoid cysts by location. Think about a clock when you go through them just to describe them correctly. So it can go midline retrocerebellar, lateral retrocerebellar, CP angle. You can be clival prepontine anteriorly, or you can sit above or below the cerebellum, and usually the quadrigeminal one is a distinct entity. The incidence of these 5 types is pretty age-specific. If you do some reading on the topic, you realize that the midline retrocerebellar cysts are frequently found in adolescents and often confused with megacisterna magna. The CP angle ones are most frequently really in adults, and the ones in the quadrigeminal pineal region are really rare and mostly found in infants, with the second peak in the second half of life around 50 to 60. It's a rare disease, I agree. Only 50 of them have been described until roughly 2000, and maybe the same number since. But it's worthwhile knowing about it because it's a formidable challenge when you see one. So as I said, quadrigeminal arachnoidal cysts are mostly found in infants. There are a number of synonyms that I put down for you here. If you do a literature research that you understand, all of this applies to the same entity. They are basically posterior to the third ventricle, sitting in the tentorial notch, and that's why they're also called paramesencephalic or parapineal cysts. They can extend into the surrounding tissue. Type 1 grows anteriorly into the third ventricle from underneath, and they can even go forward. Then there are supracerebellar ones growing up behind the third ventricle and the lateral ventricles, and type 3 is the one that grows laterally into the ambient cistern. All good to know when you describe your paper. Well, how do we make a diagnosis? Obviously by imaging. Often computed tomography is the first scan we get, homogeneously hypodense, non-contrast enhancing. Sometimes you see bone scalloping because it's a long existing developmental lesion, but the imaging of choice is MRI. You get a clear CSF signal on T1, a clear signal on T2, and you should always get a DWI to rule out a rare epidermoid, which can mimic this lesion initially. Differential diagnosis for cystic PFOSA lesion is actually fairly simple. So if you think of congenital PFOSA anomalies, it's a hindbraid malformation, it's a cystic version. Arachnoidal cyst cannot really be confused with anything maybe other than megacisterna magna, and some developmental changes that include parenchymal change to the brain, which we do not see in arachnoidal cysts. As far as the physiology is concerned, 90% of all arachnoidal cysts appear stable on sequential imaging, only 10% enlarge. And when you get the first one in your practice, you don't know which one it is, so you have to get sequential imaging. I recommend annual surveillance MRI scan. There's hypothesized mechanism of increase, either through an osmotic gradient, There may be a ball and valve mechanism. The fluid can get in but can't get out when it circulates. Or there may be internal production of secreted fluid. That has really not been resolved well. I think the most likely one is a ball and valve mechanism that depends on CSF dynamics. So I also get a CSF flow study just to visualize this. Now, clinically speaking, it's relevant because arachnoidal cysts can be associated with hydrocephalus in a location-dependent manner. For the supratentorial ones that we're not talking about today, it's usually the foramen magnum that is obstructed. That also applies to third ventricular lesions. For the 𝑃FOSA ones, there may be aqueductal obstruction or compression of fourth ventricle and outflow. So hydrocephalus is real, and hydrocephalus can be acute. Unfortunately, there are no clear guidelines regarding the indications for surgical intervention, and there's really no consensus in any of the societies what the best treatment choice is. So the usual protocol is you offer surgical treatment either when the patient is symptomatic from mass effect or hydrocephalus, or when the lesion grows. And more recently, we've seen more and more prophylactic treatment, especially in the pediatric population, once there's demonstrated growth of these lesions. Now, our next question should be, what treatment is the best? What treatment is available? Well, there are three strategies you can think about, visualized here in my pictures. You can address the causative problem. You can go after the actual cyst, and you can do this open microscopically through a classic sitting supracellular infratentorial approach. You can go retrosec or endoscopic for the 𝑃FOSA lesions. All things that work well in your hands are allowed and are suitable. You can also say, I treat this minimal invasive and just treat the hydrocephalus because it's such a slow growing lesion. You do a standard shunt or even an ETV has been done to get the patient through the acute phase, and then you have enough time to think about the real deal. But there are new minimal invasive techniques available, and you may combine these to get away with less surgery and a better outcome. So we have many treatment options available for this condition. Why would we add another one that is minimal invasive? And I want to illustrate hydrocephalus treated in 𝑃FOSA arachnoidal cyst. Well, one reason is the literature will tell you there's been limited efficacy of classic treatment, especially for the microsurgical cyst fenestrations. And the reason is a physiological one. If you think about a bubble, this is a fluid-filled bubble inside your brain, and you punch some holes into the wall of the bubble will shrink. And as the bubble shrink, the wall will actually consolidate, and the opening that you've created will close. And hence, there's a very high rate of recurrence. And even after pre-surgical, pre-fenestration in patients with hydrocephalus in the pediatric population, up to 70% of patients did require VP shunt, finally, because of recurrence and persistence of symptoms. There are also some complications associated with microsurgery, not just the usual infection, bleeding, wound healing difficulties, fluid leak, and so on, but the reocclusion rate is the one I think you need to think about. In 𝑃FOSA surgery is always a risk of pseudomeningoceles, especially with poor material available to close the 𝑃FOSA. Retrosec, there may be bleeding reported in the cyst or supratentorial from decompressing a 𝑃FOSA lesion. And obviously, if you implant a device, you have all the complications from the device. Now here, I just wrote it down for those interested to look this up afterwards. Each of these treatments has a certain constraint. So the endoscopic or open surgery has a higher rate of closure and cyst recurrence. There's also risk of vascular complications because you do a bigger surgery. All implanted device or cisternal peritoneal shunts have a risk of device failure and a high infection rate, as Kazadi mentioned. ETVs may cause initially good decompression for the hydrocephalus, but it doesn't address the pathology, so it may still grow. And combination surgery can always have higher morbidity because you have more than one thing. So I think one of the key concepts we should revisit is that in minimal invasive surgeries, you want to make a simple approach that is simple for the patient, simple to you, and possibly least invasive. It may not even require implantation of a device, and that will immediately, I think, translate into highest quality of life for the patient. So I want to guess, this was a 31-year-old patient who came to me. She was a circus artist, diagnosed with recent migraines, suddenly developed dizziness, came to the ER because she thought she had a migraine attack. Turns out she had also cognitive changes in the family, said she was irritable and slow. So this sounded more like it's not a migraine. And obviously her job performance was impaired. She had sort of a special act in this that just didn't work out. So we imaged her in the ER, and this is the lesion we found, supracerebellar arachnoidal cyst in the tentorial notch with two compartments, third ventricle and one above the cerebellum, DWI negative. Type 3, and it's a technical challenge because how do you want to get in there? So the acute problem is triventricular obstructive hydrocephalus from this lesion. So what do you do first? Do the simple things first, treat what you must treat. So we popped in an EVD in the ER just to make the patient safe, because then you have time to think. So we inserted the right frontal EVD. Her opening pressure was 35, so she was really on the verge of herniating. And post-procedure, she was immediately better. And now I had enough time in the ICU to think this through and say, how the heck am I going to deal with this? Now we have several surgical options. We can do this open or endoscopically or minimal invasive. And if you think about it, open is very familiar in many of our hands. It's similar to pineal region lesions, so it should be suitable for a supracerebellar infratentorial approach. But this is pretty challenging in this setting because the lesion sits in an area where everything you don't want to see on the way in is compressed against your entry access route. So I thought, okay, maybe we should do this endoscopic or transcerebellar, but that again needs multiple fenestrations, has a high failure rate, so I wasn't happy about this idea. And again, the compressed cerebellum is in your way because you have to somehow get to it. So I thought maybe internal shunting should work for this, because I had seen this in residency for my old boss, Chris Ostertag, who was a brilliant neurosurgeon in Germany. He wrote a paper in the 90s that is still worthwhile reading, where they treated various brain cysts internally by shunting obstructive hydrocephalus. And the concept here is, if you have a lesion somewhere buried deep inside, don't try to chisel this out. It may be good enough to just place a catheter, just like an EVD, through the natural space, the ventricle, into the cyst, and then drain the cyst retroactively into the ventricle. So after aspiration of the cyst, you leave the catheter in place to get an internal shunt, no implanted valve. And this is the result after 12 months. They had done this in this beautiful paper for 27 patients, both supratentorial and infratentorial. 75% of patients improved tremendously right after the surgery, became symptom-free. 5 more improved clinically, but still had the cyst in there. Only 4 of the 27 had treatment failure and required some shunting. That's a number much, much better than what was described in the literature. And I just remembered this paper and I thought, maybe this works for me. And I had done this once before in residency. This was my case. So I had done this supratentorially with a massive arachnoidal cyst interhemispherically anteriorly with lots of septations. I didn't want to go in there and sort of, as a chief resident, chisel this out. What we did is we made a mini opening and tunneled a catheter from the frontal cyst into the lateral ventricle. And as you can see from a massive cyst at presentation, the cyst did shrink and equilibrate, and the patient became asymptomatic and is well now. So I thought, why not do the same infratentorial? So this is what we did. It just required more planning. Surgical planning for this cyst came in 2 steps: a frame-based stereotactic cyst puncture, which I did coming from the top down, going into the cyst and aspirating 40 cc of the volume of this particular cyst. Then I left a shunt behind, an internal shunt, draining the cyst again backwards, supratentorially into the lateral ventricle by putting a basic EVD catheter, a Holter catheter in, and clip it to the dura by a Rickham reservoir so it wouldn't move. And I thought this should work well, and see what happened. This is the initial presentation on the left side in the ER. 2 weeks later, the cyst after aspiration was already significantly less. And a year and a half later, the cyst has almost disappeared. The cerebellum has re-expanded and the patient was asymptomatic and doing well back in the circus. So I was happy that I used one concept from one area and transplanted it into this idea. We published this in 2019 as a case report. Next case is a similar case. You think initially 55-year-old man presents with headache, balance difficulties for handiwork, some ataxia, dysmetria, gait instability, nystagmus, so again cerebellar dysfunction. When we look at this scan, this is the patient, again a big supracerebellar cyst sitting just below the incisura in this case, but biased towards the left side. You can see that the lesion sits in the incisura but doesn't reach above it. And there was again superior cerebellar compression with symptomatic. There was near occlusion of the aqueduct, and there were peripheral membranes but no vessels. So I thought, wow, should I do it just the same way we published this? But I realized there's a narrow corridor from superiorly to get into this cyst from the top down. You have to go through the ventricle to get to the cyst, which is not so easy. So maybe I do this differently. So we looked at this patient, we realized there was this lateral component. If you go one scan back up and you see that the cyst reaches the retrosig area here. So for this case, we decided to do minimal invasive, but supracerebellar, infratentorial, fairly lateral, minimal invasive opening, just the size of a dime. We made a mini opening and we put a catheter into the cyst and then left the catheter retrocerebellar, infratentorial, behind the tonsil in the subarachnoid space to drain the cyst into the same compartment, and we could just close up. There was really no significant risk, no morbidity, and we left all natural structures intact. And you can see that there's just an internal shunt, again, tied to the dura so it wouldn't move. And the result was remarkable. The patient was out of the hospital day 2 with complete resolution of neurological symptoms. So my conclusion here is, for certain cases, less is more. Less surgical invasiveness gives more quality of life to the patient. So briefly, executive summary for today's talk. These arachnoidal cysts are rare, congenital fluid-filled compartments. P-fossa lesion is even more rare and difficult. However, they can cause acute decline from hydrocephalus. There's really no recipe you can use from the literature. So use what works well in your hands and think about what is simple to the patient and simple to you. You can think about open microsurgery, and if you're comfortable in it, it often does work. You can use stereotactic techniques. We talked about 3 treatment concepts, either addressing the arachnoidal cyst itself or treating the hydrocephalus, or combine this. I wrote down that we can do microscopic or endoscopic ventricle to cyst shunts or cysternal shunts. We can also drain the cyst into the peritoneum itself. But I very much like the minimal invasive stereotactic drainage of arachnoidal cysts with just a proximal catheter left behind, no valve. It's cheap, it's fast, it's effective, and has very little morbidity. Thank you very much for your attention.
Thank you, Dr. Kasper. That was a fantastic overview of a very complex subject. To tell you, if one subject bothers me, one subject disturbs me, it is arachnoid cyst. And as you rightly said, the most important question is whether something is required to be done or not required to be done. That is the primary and the main issue in arachnoid cyst. As you know, I'm not sure if I'm correct to say that have you heard of McLaurin? Robert McLaurin was a very famous US neurosurgeon. And he had once written that fluid in the brain is not a problem. Fluid under pressure might just be an issue. This is what he had written, McLaurin. And I completely tend to agree with what he has said, that most important issue is find out whether this arachnoid cyst is indeed the cause of symptoms. Like in adults, for instance, many patients will come with headache, and headache everyone has. That does not mean that arachnoid cyst needs treatment. And if you treat, you might harm the person. So, and how to treat, whether it is minimal invasive, whether it is some kind of a shunt, whether it is kind of some CSF diversion, whether and what. I think very good overview, Kasper. I enjoyed the presentation of a very complex, difficult, and to say the least, a controversial subject.
Thank you.
So I would like Azra Afoji to
yeah. Yeah. Thank you, Ek. Nice to meet you here. Thank you, Professor Goyer, for very nice explanation about this kind of disease. Thank you, Ek, for your nice presentation. I think you showing us a new perspective in the treatment of RNPs. Yeah. And yes, in our institution, mostly our pediatric surgeon doing the microsurgery and sometimes with endoscopic surgery. So I think, yeah, you showing us some complex cases. I mean, the location of the RNP case is, challenging, but you showing us how you use the strictly something procedure, this minimal invasive with maybe a simple treatment, but I think you showing us the outcome is very good and similar to other kind of treatment that already did by other neurosurgeon. So thank you for your new information for us. Thank you, Eke. Thank you. Yeah.
I think thank you, Eka. Thank you very much. It's very excellent talk, I think. But sometimes it's just a cyst is communicate or non-communicate or half communicate. So how you can differentiate the cyst?
So as Abdul said, I think the most important thing is observe the patient first and figure out, is the symptom from the cyst or not? And does the cyst actually change over time? If there's a non-communicating cyst, it would be unusual that it grows, right? Because it makes no sense. Where would it come from? There's no choroid plexus in it. So that's why people have said you need to get sequential imaging. And yes, if some of them grow for whatever weird reason, for me, the physiology has to be a slow one, and the pressure inside the cyst cannot be high. It's not the cyst that has a lot of pressure on the cyst wall. It's maybe the mass effect in the hydrocephalus. So I think this idea of shunting the cyst to a low pressure compartment like the peritoneum is a bizarre concept, because you will deflate the bubble immediately, but you have no driving force to get the fluid out. So if you put a valve in there, where would you set it? Because there's really no pressure. And if you shunt the cyst, it will probably occlude because it gets smaller again. So if you stay in the same compartment in the brain, you equilibrate the same compartments. And I think it helps that you get less complications from deflating the bubble too quickly, right? So if you shunt the cyst to the ventricle, you could inject some dye. We've done this actually when I was in Ostertag's group in Europe. We used intraventricular dyes and just injected the stereotactically punctured cyst, and you would see, does it communicate? If it does, you're already in a better shape, right? Because it probably drains. If it doesn't communicate, then you need a reason to leave the catheter behind, or you shunt it somehow. I get CSF flow studies, but you don't, most of the time you don't see fluid inside, outside communicating. So my gut feeling is, if it's a true arachnoidal cyst, it doesn't communicate. If it's an arachnoidal adhesion with septations, there may be some that do communicate, but that's also the reason why fenestrating it is sort of a weird concept. We need to puncture multiple holes, front and back and side. And there are all these vessels running through them, and when you shrink the cyst, they often bleed from these weird vessels. Everybody's afraid of, the hemorrhage post-fenestration. And I think that's a complication we can avoid if we just don't fenestrate it the conventional way. I'm not going to lie, supratentorially, temporal lobe, I still fenestrate microsurgically cysts that are there. That's just the way to do it. But the idea to leave a catheter behind that keeps the connection from the inside to the cyst to the outside of the cyst, which can be in the cisterns, I think is a good one.
Yes. Thanks so much.
You thought you have a question?
Dr. Muhammad Daliev, you have Question or comment?
Yeah, 𝒓𝒐𝒇. Hello, Please unmute yourself, 𝒓𝒐𝒇.
Unmute, please.
We can't hear you.
We cannot hear you, 𝒓𝒐𝒇. Please connect your phone microscope to the phone microphone to your screen.
Still, we cannot hear.
Okay. If you cannot speak, can you type your questions in the chat box?
Maybe I think later. Okay.
So maybe we can move to the next presentation from Professor Gleb Danilov for the presentation on implementation of best research practices in applied neurosurgical sciences, insight from Burdenko Center for Neurosurgery. Professor Danilov, please.
Dear Professor Kata, dear Chairman, dear colleagues, thank you for this opportunity to speak today, and I would also like to extend my gratitude to all the organizing for putting this webinar together. I would also like to say a huge thanks to Professor Sharma for a wonderful introduction into neurosurgical research, and I want to share some thoughts on how to apply the concept of evidence-based medicine to neurosurgical research, since this presentation is primarily aimed at young neurosurgeons. I'll share our experience in implementing several key principles at Burdenko Neurosurgery Center, which is in Moscow, Russia. We hope, my hope is that this insight will be helpful for those looking to conduct well-grounded research in neurosurgery. This is the way we typically see the concept of evidence-based medicine, which is based on the doctor's experience, the patient's values and preferences, and the best clinical evidence available. Let me walk you through the steps we'll take to bring this concept to life. First, we need to identify a specific question related to clinical practice that comes up when you interact with the real, actual patient. What should we do about that question? We try to find the answer in scientific literature. Typically, we search PubMed or any other database. The results of studies we find should be critically appraised before the publication. Then comes clinical practice and evaluation of our decision. What if you are not that satisfied with what you've learned from literature? That may be the motivation for your own research, starting with inclusion criteria, the selection of appropriate design, going on with data collection, data analysis, and finally publication. And I want to mention that information technologies may be applied at any stage of that scheme, typically focusing on design, data collection, and analysis. Why should we even talk about the evidence-based concept? The reason is, despite the recognition of evidence-based practice and research worldwide, these principles are underused in real life. Let me show you an example in our specialty. The authors from China have published a report on almost 7,000 publications related to evidence-based medical practice in neurosurgery. It's a bit outdated, but still important. The majority was produced by English-speaking countries. It may be really helpful to understand what's going on with high-quality research in neurosurgery. 24% of studies they identified were designed as randomized control studies. The leader in publications was Canada. The funding source was stated in less than 50% of randomized clinical trials. More than half of the RSTs were directly funded by industrial companies, and government-funded agencies accounted for no more than 1/5 of the randomized clinical trials. Another group of authors came to similar conclusions by analyzing neurosurgical publications. They noted that the number of randomized controlled trials in neurosurgery is small, the quality of trials is low. That probably means that the evidence-based principles are not that adapted as they are talked about. Evidence-based research and practice is a big topic that can be seen differently through the different professional thinking of doctors, research professionals, informaticians, and healthcare authorities. It might touch you differently depending on who you are. I'm not sure if you agree, but I believe that a clinician's skills alone aren't enough for research today. To ensure high quality research, expertise in biostatistics, information technology is also essential. To keep things simple, let's categorize the specialists needed for research into two groups: doctors and IT specialists. In fact, we all know that a view of a clinician and a view of informatician on evidence-based medicine may be unequal, which is probably related to the professional background. What we believe is essential for successful cooperation between medical experts and informaticians is the intersection of professional scopes. In the ideal world, we would want the intersection to be as extensive as possible. This can be achieved by shortening the distance between a doctor and a computer scientist in their professional vision. But is it always the case in real life? Can we honestly say that this distance is short and we all speak the same language when it concerns clinical research or evidence-based practice? I'm afraid that the answer is not that straightforward. What should you place at the intersection of clinicians and informaticians' professional scopes? Here is our list that can be argued or modified, but we put ethics on the top. Then comes the concept of clinical evidence, research planning framework, data collection principles, data analysis principles, and reporting research results. Ethics is the ground for research planning. Here I refer to a famous declaration of Helsinki. Ethics necessitates proper research regulations, but takes precedence over laws. Ignoring ethical principles is costly tragically. A very famous example is a thalidomide tragedy, an underregulated drug market release. Thalidomide is a molecule used to treat cancer, number of skin conditions, human immune deficiency virus. The birth defects caused by thalidomide led to the development of greater drug regulation and monitoring in many countries. And we do believe that, first of all, ethical principles should be recognized equally by medical specialists, doctors, and computer scientists, informaticians, biostatisticians, etc. Differences in views between doctors and computer scientists can relate even to those issues that seem universally agreed upon. I'm really curious if you ask your fellow doctors why we use statistical analysis in clinical research. Why do we need statistics? What would their answer be? The professional would say something like, we use statistics to test scientific hypotheses, but in most cases, I interviewed my medical colleagues. They were focusedly interested in p-values, in p-value as an indicator of success or failure in their research. Because of the nature of medical training and practice, many approaches necessary for professional research are not at the forefront of doctors' professional thinking. That's why the culture of well-designed research is not taken for granted in medicine. The quality of research outcome cannot rely solely on doctors, nor can it be completely entrusted to informaticians, computer scientists. But I would say that IT specialists are much responsible for research outcome. That is why computer scientists should have a good understanding of clinical research, ethics, regulations, and methodology, ideally close to that understanding of medical professionals. I represent Burdenko Neurosurgery Center, which is the biggest neurosurgical facility in Russia and one of the biggest in the world. On the slide, you see the annual number of operations over the last 24 years. That activity is quite intensive for neurosurgery, generates a lot of data that can potentially hide valuable information on human brain functions and pathology. So this secondary use of that information, of that data, in scientific research is absolutely justified in our center. Today, I want to share a story on research practice modification that I was deeply involved in the last 10 years, and I invite you to reflect on whether this case is relevant for you or not. What exactly we want in our center is to constantly improve the level of research quality and evidence, to increase the efficiency of secondary data use, to improve the quality of data collected in our research, to increase the likelihood of papers acceptance in high-ranked journals, and to increase the number of paper citations. At Burdenko Neurosurgery Center, we have established a laboratory of biomedical informatics and artificial intelligence. You see our team on the slide. The mission of our laboratory is to provide routine support for clinical research and to advance artificial intelligence in neurosurgery. Today, we are well equipped with supercomputers and data storage, and I think that it's quite clear that our commitment to support clinical research. But why do we need biomedical informatics and AI laboratory within a clinical center? The first reason is to increase the intersection of medical and technical scopes that I have already talked about. In addition to that, we believe that the success of AI technology is not only linked to highly efficient deep learning models or any models, but more importantly, to accurately defining the problems that truly need to be solved in neurosurgery, especially using automation, machine learning, for instance. You need to define that task. You need to find someone who can translate from neurosurgical language to the language of data science. That's exactly what we do. We are working inside medicine and healthcare, and we support neurosurgical research, and we do AI prototyping. So we act as an interface between clinic, science, and industry. What are the key principles and technologies we promote in our research activities on a regular basis? They're quite simple, not any news. They are research planning, biostatistics, data management, reproducible statistical analysis, and medical writing and project management. The technical aspect of research starts with a carefully crafted plan, usually written as a protocol. While creating a rigorous research plan, it's a well-known principle, it's often underestimated and even overlooked by doctors. A well-defined research protocol sets the stage for all subsequent steps in our research, in all the research processes, and it greatly influences its success. At Burdenko Neurosurgery Center, we developed a protocol template, which includes the sections you see on the slide. The template fits well with good clinical practice standard, and it really helps to plan the research consistently. Biostatistics. This technology is overrated and underestimated simultaneously. Biostatistician participates in study planning and writing a research protocol, translate the main hypothesis into a formalized version, chooses research design, defines the set of data to collect, picks up the statistical tests, calculates sample sizes, performs data analysis. Even if doctors can do some statistics on their own, and today it may seem easy with modern software, we believe it's important to involve such a specialist in a clinical research team. And even if you don't have enough money to afford a good biostatistician, you can always ask your fellows from pharmaceutical industry. You may be surprised by finding someone who will be eager to help you without any serious money. Data management, it's a key process aimed to ensure the unambiguity, completeness, security, and reliability of data collection and storage in your research. The efficiency and quality of data management are assured using clinical data management systems. At Burdenko Neurosurgery Center, we have a standalone clinical data management systems since 2017. We are happy with the types of systems. They significantly changed our capabilities of data handling, to be honest, at little technical cost. And that type of systems provide the facilities to conduct multi-center distributed studies. The statistical analysis today is important to make statistical analysis reproducible, and it becomes reproducible with code written in programming languages. Scripts are especially useful for ensuring reproducibility when data analysis needs to be repeated multiple times as new data comes in. Reporting the analysis procedure in code is another quality control tool. Documenting the analysis process in code acts as an additional quality control measure. So at Burdenko Neurosurgery Center, we usually rely on R programming language for standard statistical analysis, while we use Python for certain deep learning projects. Project management. This idea is straightforward. The team, timeline, and resources should be managed to get the project done. When it comes to publishing results in medical journals, writing a text in proper English is only part of the task. Complete and clear reporting of research results is no less important for the subsequent correct interpretation. The Equator Network is an international initiative aimed at improving the reliability and value of published health research literature. They provide guidelines for transparent and accurate reporting. Nowadays, many medical journals require authors to follow these guidelines when submitting a manuscript. However, we believe it's important to adopt these guidelines as best practice in every research report. Finally, I want to show how the adherence to these principles of research practice may affect publication activity and quality at your institution. You see the number of publications in peer-reviewed journals at our center in a period between 2014 and 2024. The diagram below shows the annual proportion of articles in their international journal, and you see the trend, a constant increase in the proportion, this proportion over the last years. So that indicates the interest of researchers to present their data to the international community. And this shows that the worldwide visibility of our research is also important. And it has improved over the years. So in conclusion, we think that the competences in clinical research extend beyond solely medical expertise and computer science. Doctors and informaticians should share as much of common perspective on evidence-based clinical research and practice as possible, and the introduction of systematic and multi-competent research support focusing on best practices can significantly enhance scientific productivity in medical organization. And I want to stress this idea that you have heard today before from previous speakers. That's mostly not the question of money, but it's the issue of some cultural changes and the way of thinking when you plan your research. So thank you so much for listening to me. Thank you.
Well, thank you very much for this wonderful. I'm very happy to hear one is I'm happy to hear your voice. Second thing is I'm happy to see your attitude. And I'm happy to see your positive attitude. And I think that positive attitude is very important if we have to do something like neurosurgery. In neurosurgery, we have to be positive, and we have to, we have to just go ahead and do the best we can. And if we want to cross a line, if we want to do good neurosurgery, that is important. But if we want to go beyond good neurosurgery, we have to do some kind of innovation, some kind of research, some kind of novel thoughts. We have to do, go in a different direction. No little idea can be, undermined. One little idea is bigger than 1,000 people operating for 1,000 years. So we should look for ideas. We should look for concepts. We should look for philosophies. Technique is one, technology is another one, but philosophy remains. Concepts remain. So we should have solid concepts, solid philosophy, and then we should use that philosophy and concept to make our techniques good, and our technology will support us. But what is more important is understand the subject and follow the subject in the right direction. Just listen and do and this and that is not important. Have solidity in your thoughts. That is what my message to all young people is.
Thank you so much.
Professor 𝒕𝒔, 𝒂𝒂𝒂𝒂𝒂.
You hear me?
Yeah, do you have any comment on the presentation?
Yes, thank you, Professor Davidoff, for your presentation. I think this is very important for doing a research from the own institute, because the research can be presented how it's working in the neurosurgical field, and if we interest in the innovative field, and especially in the minimal invasive neurosurgery. I think this is cause more valuable for our society. Thank you, Professor.
Thank you so much. Thank you.
Mohan?
Thank you. Dr. Danilov, excellent presentation. I totally agree with you. One question I have to you is, how do you handle the conflict with the industry while you conduct research? I'll give you the example now. No more randomized control trial will be done, comparing endovascular versus microsurgical clipping of the aneurysm, they say, because there's so much of industry involved in endovascular thing. So how do you approach this issue of industry, huge industry interest?
Thank you so much for your question. I do believe that we do not have such a big problem, dealing with industry, because there is an ethical barrier for industry to be involved in our research. We are funded by government mostly, so we are responsible for our research in front of governmental funding agencies. So industry doesn't influence our position that much. I hope that this is the answer to your question. I hope.
So thank you very much, Daniel. It's a wonderful talk as always. I think maybe your high knowledge of the AI, we can support the writing some papers in the future. Thank you so much. Thank you. Excellent talk.
Thank you so much. Thank you.
Thank you, Professor Danilo, for the presentation. Dr. Dison Mamadaliev, do you hear me?
Yes. Do you hear me?
Yeah, now I can hear you. Professor Eckhart, Dr. Dison, I have a question for you.
Well, I really very much like that you presented the structure of how to conduct research in the evidence-based concept. I think we all need to improve the quality of what we write, because it's not about quantity, as Mohan had said. It's better to write one good paper per year than 3 crappy papers per year. But I want to also tell all the younger surgeons, it's really a learning skill that needs to be acquired. Nobody, knows this when they wake up at 8 a.m. before residency day 1. We all need to learn this as we go. Atul said we need to write case reports. We need to write case series. We can use large volumes that are available to us in the developing countries as the best material, because you have these patients. Many of the developing countries have many centers and hence very small numbers per center. for a particular disease. And if we start doing this systematically, doing the literature research systematically, use AI for proper algorithms to help us identify the targets, we will just generate much higher quality data, and even experience can rely on a good structure and is contributing to the literature in itself. So I just wanted to comment and say, Gleb, you did a fantastic job. I think this is inspiring, and thank you for bringing this.
Thank you so much.
Professor Caspar, Dr. Dinson have a question for you regarding the previous presentation. Now he connected, and please.
Professor Caspar, thank you. And both Professor Danilov also, thank you so much for the excellent presentations. My questions is for Professor Caspar. I very much appreciate your idea of connecting two compartments and in the treatment of arachnoidal cysts. And my question is, how do you puncture the arachnoidal cyst when it has the thick wall? And because in some cases, when we used to fenestrate the arachnoidal cyst using endoscope, it caused some problems, and it was difficult to sometimes just fenestrate and doing a cystocernostomy, but you are doing it just placing the shunt between arachnoidal cyst and the ventricular system, if I understand.
So really good question, because some of the arachnoidal cysts can have a fairly thick membrane that is like collagenous, and it does require a little bit of chutzpah or courage to puncture that cyst. So the way we did it is similar to a stereotactic biopsy needle. I do this in a fixed frame, not freehand, and I bring a guide tube towards the cyst wall. And then you have two opportunities. You can burn with the monopolar a small access point, and then you actually use a sharp trocar through the guide tube that punctures the cyst wall. Or you can use a mini forceps. There's a special company called MHT in Germany that used to make forceps that are 1 cubic millimeter in size, so 1 millimeter tip size. You thread this thing to the guide tube and you bite a mini hole into the cyst wall. That's your access point for the catheter. So first you bring the guide tube to the cyst wall, open the cyst wall, then you push the guide tube another 5 millimeters in, so you know you're inside that particular cyst. Then you can aspirate whatever you want to aspirate, or you push it further in to be in the center of the cyst for your aspiration, right? Because then you can sort of expect a concentric contraction of the cyst, and then you use the guide tube either in itself or the trajectory to place the catheter exactly along the same pathway, which you can do inside the guide tube if it's thin enough or outside. So you need to think a little bit about how big a catheter you want to thread into your deep-seated structure. So if I come from the top down, going through the lateral ventricle into the third ventricle or into the P fossa, I want to have a fairly thin catheter, right? I don't want to put a 4 millimeter big hemovac drain in there. I want to put a Holter ventricular catheter is 2.1 millimeters diameter. There are different versions. The ones from Codman, 2.1 millimeter outside diameter, 1.4 millimeter inside. If you have a proteinaceous cyst, you maybe want to use a 2.8 millimeter. That's the thickness of your catheter, and it needs to be fairly straightforward how you get it into the cyst. So that's sort of the skill you need to acquire a little bit. I wouldn't start with a P fossa cyst on day one, but draining a larger supratentorial cyst this way, just like in EVD, it's really the same concept. You have a stylet inside the EVD, right? You can use the stylet to advance your catheter, but it has to be absolutely stereotactically along the catheter tract. And if you have a blunt tip of the catheter, advancing the catheter slowly to the brain will not rupture a vessel. The vessel usually is pushed aside by the blunt tip of the catheter. So I've never seen a real bleed from it, right? If you use a plastic, it is better than using the hard PVC. Some of the Omaya reservoirs used to come with a transparent PVC catheter that is very firm and stiff. I think that's too sharp, right? So use something that is sort of intuitively gentle. But your question is a good one. And yes, for the stereotactic ones, it's tough to open. For the open ones, you can just thread it in.
Thank you so much, Professor.
Please unmute yourself.
So for the next presentation, maybe I would like to invite Professor Shunsuke Naka for the presentation on glioma and glioma-associated epilepsy.
Sensei.
Can you see my screen?
Yes.
Please click it to the presentation mode.
So my name is Shunsuke Nakai from Fujita Health University. As today, I'd like to talk about glioma and glioma-associated epilepsy, including on research and glioma surgery. So, glioma often cause epilepsy, and lower-grade glioma have a higher chance of causing it, especially glioma with IDH mutation are known to cause epilepsy in about 60 to 75%. These lower-grade glioma usually occur in younger people and have a better prognosis. However, if epilepsy becomes hard to control after tumor resection, it can make it difficult for patients to walk or live a normal life. So it's important to manage not only the tumor, but also the epilepsy. So there are several theories about why epilepsy frequently occurs in glioma, as shown here. But generally, it is considered that the increase in extracellular glutamate level is strongly related. To investigate the relationship between this rise in glutamate level and the occurrence of epilepsy in glioma patients, we conducted a quantitative analysis of tumor metabolites using MRS. So this is a method. As expected, the frequency of seizures and seizure outcomes were higher, were worse in glioma with IDH mutation compared to IDH wild-type glioma, such as glioblastoma. Interestingly, MRS studies showed a glutamate level is much higher than in the IDH wild-type glioma. This finding is consistent with other MRS studies and research on tumor metabolism. As shown in this table, the MRS study did not find a significant link between epilepsy occurrence in glioma and glutamate level. Instead of glutamate, NAA, which is known as marker for normal neuron, is significantly associated with the occurrence of epilepsy. It is known that one of the glutamate receptor, AMPA receptor, is also expressed in glioma cells. Interestingly, a recent study showed when glutamate binds to AMPA receptor on glioma cells, the tumor cell grows. The study mentioned the perampanel AMPA receptor antagonist is a candidate for further preclinical studies and clinical trial in neuro-oncology. Another study compared the effect of 4 anti-epilepsy drugs on glioblastoma cell lines reported that only perampanel was able to suppress tumor growth. So based on these reports and our research findings, I thought the mechanism of epilepsy associated with glioma works as follows. It's been traditionally thought that an increase in extracellular glutamate concentration is related to the occurrence of epilepsy in glioma. However, in reality, glutamate levels were significantly higher in IDH wild-type glioma, which have a low rate of epilepsy but high malignancy. On the other hand, it has been shown that glutamate bind to AMPA receptors on glioma cells contribute to tumor growth. So in higher malignant glioma with a high density of tumor cells, glutamate is more likely to bind to the tumor AMPA receptor, promoting tumor growth. In contrast, in low-grade glioma with a high proportion of normal cells, glutamate binding to the AMPA receptors of normal neurons may promote epilepsy. So this research is discussed today detailed in this paper we published previously. So what population of glioma patients presenting with preoperative epilepsy in my own cases to accurately assess the prevalence of epilepsy and including seizure frequency? And I looked into 90 patients, and out of these, 58 patients underwent tumor resection surgery. Out of the 85 glioma patients who underwent surgery, 55% had epilepsy. So I categorized the patients into 3 groups, as shown here, and I focused on the high frequency group. This table shows the age, seizure frequency, tumor location, and pathological diagnosis of glioma patients who experienced monthly or more frequent seizures before tumor resection. So about 30% of the patients in the high-frequency seizure group had glioblastoma. On the other hand, in terms of tumor location, about 80% of the tumors were located in area including hippocampus, paracampus, gyrus, and the insula. So this suggests that preoperative high seizure frequency is more strongly associated with tumor location than with low malignancy. So I think it is important sufficient resection is important for improving seizure frequency in this area. So if we see a tumor located in these areas, we usually assess diagnose whether the patient has epilepsy or not, and also check the memory function and decide the surgical approach. I think there are mainly 5 routes to approach the inferior form as shown in these illustrations, from above and outside and below, and from the front and from the back. But in the case of tumor, it is usually very large, so we usually select anterior temporal lobectomy to resect. So let me show you the ATL surgical procedure. First, the tip of temporal lobe is resected. to create enough space to remove the tumors. And next, we identify the inferior horn and reject the tumor and here. And posterior limit for safe resection using this approach is up to this line. ATL is a commonly chosen surgery for temporal lobe epilepsy. In epilepsy surgery, the normal structure of the major temporal lobe is typically preserved, and since the hippocampus is often atrophied, it can be removed even through a small surgical corridor like this. But with tumors, the normal structure of the major temporal lobe may be disrupted, and the hippocampus is often swollen, and the pia mater, which borders the brainstem, may also be damaged. So this abnormal anatomy can cause disorientation, and supine resection may not be safe in these cases. So next, I'll talk about the insula resection. Surgery for the insula is very challenging, very different between epilepsy and glioma surgery. In both cases, the Sylvian fissure is often widely open. But with glioma, the insula is often swollen, making the anatomy understand. Also, in epilepsy cases, deep resection is rarely required. So let me talk about the Sylvian fissure dissection. So this is a case of a left posterior insular region. When I dissected the Sylvian fissure, I usually start by tearing the arachnoid with two forceps. After removing the superficial arachnoid membrane, I use scissors and suction to separate the Sylvian fissure. If there is any bleeding during the process, it becomes much harder to treat the Sylvian fissure. In area without blood vessel, I can use scissors like a spatula to gently separate the brain tissues. And you can see insular cortex here. And this is the usual procedure we followed for this dissecting the Sylvian fissure. Since 2019, we have performed glioma surgery on the major temporal lobe and the insula in 20 cases. Let me present a case, and this is a woman in her 60s, and her medical history and the test results are shown here. And let me show you the MRI image. The tumor is extensively spread around the hippocampus and the parahippocampal gyrus. The head was positioned strongly vertex down, so I don't think awake surgery is recommended for hippocampal tumors. Here is a surgery video. First, I dissected the Sylvian fissure, and it was the insular cortex. Then I identified ICA and the optic nerve, and remove the tip of the temporal lobe. Maybe I don't know. So I identified here the inferior horn here, and look for the internal structures, but I couldn't find. The brainstem and the PCR is a good marker for the internal structure of hippocampus. So I was still looking for the inner structures called the plexus, but I couldn't find in this surgery. This is outside of hippocampus. Maybe I don't have enough time. So in this case, understanding the anatomy was difficult because the hippocampus was extremely swollen and inner structure couldn't be found. But this is relatively common. But I think the key point is that the innominate circus is always identified. And if it excites downward, you can reach tentorium. Your MRI image of the surgery. And this is a different case. During surgery, I couldn't find the chord plexus, but the pathology plots show the chord plexus was so atrophied. So in your case series, this is almost half case. We couldn't find chord plexus during surgery. Next, let's talk about visual field loss. ATL often leads to post-operative visual field loss, but it depends on the patient. Optic radiation typically runs as shown in this image. So when we want to avoid visual field loss, we choose a route that approaches the inferior horn from the front. This case is a tumor located in the right ankle and the hippocampal head that was associated with epilepsy. So we choose the anterior approach in this case. Let me show you the surgical video. After dissecting the sylvian fissure, the tumor was identified here. This is the pranum polare. The tumor was carefully excised from this point, moving towards the back. So here I found the inferior horn here. And you can see amygdala and ankles and the hippocampus were all connected. And hippocampus was resected posteriorly. And the tumor is almost resected. And in this patient, no visual field loss in this patient. Next, I will present a case where the tumor was resected using both ATL and anterior approach. This is a woman in her 60s who experienced daily seizures. The operative MRI showed a significantly enlarged tumor. In the first surgery, I couldn't resect tumor enough. This is because I'm not sure whether the tumor compression or not, but cavernous sinus was not detected in this patient. And this is preoperative angiography, and sylvian fissure is drained via temporal base vein to the transverse sinus. So that's why I think it is bleeding too much to resect temporal base. So second time, I changed the approach route from anterior. So I dissected sylvian fissure, and this is the pranum polare here. And then I resected the tumor to posteriorly. So this is So this is the oculomotor now. So using this method, we can detect the tumor around ambient system. Finally, I will talk about the initial glioma. As this paper showed, detecting posterior and superior insula is very challenging, especially in the posterior superior insula. So this is the case of insular glioma, and I will show you the surgical video. And this is the insular and very shallow. I confirmed that the severe fissure was dissected up to the posterior edge of the tumor. And the patient was awakened, and we identified the peripheral gyrus by stimulation. We detected the fulcrum in the awake state carefully, exciting the tumor while skeletonizing. So this is the temporal side and this is the frontal side. Usually, I don't use bipolar or stop breathing in frontal side. The tumor was almost completely detected and the patient has been doing well post-operatively with a tumor recurrence or seizure recurrence. Sorry, I don't have time. So this is the conclusion. Thank you very much for your attention.
Gliomas and epilepsy are very important issues. Whenever there is a glioma and whenever there is epilepsy means the tumor is active. Tumor is disturbing the brain. Tumor is progressive. Tumor is of a higher grade. Suppose there is a tumor without epilepsy and tumor with epilepsy. Obviously, tumor with epilepsy is more irritating, more aggressive, more active, and a higher grade tumor. More the number of epileptic seizures, more the aggression of the tumor. So we have to, when we are removing the tumor, we have to remove the tumor and we have to remove the tumor aggressively. That is the, you see in the earlier days, low-grade glioma surgery was, people were doing very limited resection or small resection. But to remove the tumor aggressively is not only to stall the symptoms or remove the symptoms of headache, of higher functional disturbance, but also of epilepsy. And also reduces the malignant transformation of these tumors. So it is very important to understand low-grade gliomas, understand where they are located. If they are located in medial temporal brain, which is already an epileptogenic area, as we have heard just now, if they are located near the amygdala, near the hippocampus, near the medial temporal structures, whether we have to remove the tumor and with the tumor we have to remove the amygdala and hippocampus, whether we have to do ECOG guided tumor resection, whether we have to do, apart from tumor, we have to understand the sensitive epileptogenic areas around the tumor, particularly in the medial temporal structure. So this is a very important lecture. And I think a lot of things to learn from this lecture. Thank you very much.
Thank you. Thank you very much.
Maybe I would like to invite Dr. Ben, you have a comment or question?
Yes, and thank you, Professor Aki, for your great lectures. And I'd like to ask about during a surgery, any intraoperative monitoring that you monitor, for especially about whether you monitor the ECOG intraoperatively. And yes.
So you're asking me what kind of neuromonitoring during surgery we use?
Yes. And do you monitor the seizure activity during the
usually MEP, SCP, CCEP, and ECOG.
Yes, I see. Thank you so much. And I think I think it's important when you consider the surgery with the government. And yeah, thank you so much for that.
But Aniaku, do you have question or comment?
Yes, thank you. Thank you so much, Fam. Good evening, Professor Yoko-Kato. Thank you.
How are you?
Thank you, I'm fine. Good evening, Professor Atu and Professor Adida, my teachers, our trainers. Thank you so much. Good evening, professors. Good evening, good morning, good afternoon, professors, senior colleagues and colleagues. My name is 𝑰𝒑𝒂𝒊𝒄𝒉 from Nigeria, a young researcher from Nigeria. Yeah, thank you, Sonke, for the presentation. Please, what techniques do you adopt in maximal safe resection of low-grade gliomas? And when you have intraoperative seizures, how do you control intraoperative seizures? And in your experience, insular gliomas are usually associated with olfactory hallucination. Are they really common in your cases? Thank you so much for this great presentation.
Thank you very much for your question. First of all, we usually do awake surgery to do the maximal safe resection.
Okay.
So, during awake surgery, important thing is, I think, to prevent seizure during surgery. So we usually continuous monitor EEG monitoring during surgery. So when we stimulate, we always check the EEG and not to cause epilepsy during surgery. So that's how we do during surgery.
Okay. Thank you. Okay. So olfactory hallucination is known that insular tumors, insular gliomas are associated with olfactory hallucination. Is it common in your practice?
I don't think not so many cases about hallucination. So I don't know about that.
Okay. Okay. Thank you so much, sir. Then what technique do you adopt? You know, tumor brain boundary is difficult to delineate in low-grade gliomas. For maximal safe resection, what techniques do you adopt?
So awake surgery. I think awake surgery is the best.
Okay. Okay. All right. Thank you so much. Thank you so much.
Dr. Afia, you also do a lot of surgery on glioma and also research as well. So do you have any comment or question?
Thank you, Pham. Dr. Nakai, that was a nice presentation. And I was just wondering whether you would prefer, that huge tumor you showed, which was going anterior and posterior, the last one, where you used two approaches. If you had taken probably a transcortical middle temporal gyrus approach, which we have described, Professor Goel has described that, if you go in the anterior part of the temporal horn, there are no visual fibers that you will affect. The optic radiations are in the roof anteriorly and posteriorly then the lateral part of the temporal horn. So if you go there and if you probably use that approach, I think you would have gotten the whole thing in one go rather than, a two-stage approach. And for mesial temporal tumors, we generally prefer this transcortical approach. So, I mean, what is your preference? Why do you like to go through the Sylvian fissure and go through the plenum polare for, what advantages does it have over the transcortical approach? Because we are able to preserve optic radiation vision fibers even with this approach.
It depends on case, I think. So, yeah, so as I showed in my table, I usually, in many cases, I select a transcortical approach because to dissect Sylvian fissure is troublesome and take a lot of time. So, yeah, but it depends on case.
Okay, thank you.
Another question I want to ask.
Okay, thank you, Professor, for excellent presentation. I just like to know, you find about 52% seizure before the operation. Is the operation rate become lower after surgery or not changed? Thank you.
So are you asking post-operative seizure?
Yes, please.
Usually it disappears. Almost 90% disappear after tumor resection.
I want to ask one question to you. I want to know what is your take on en masse resection? En masse, going around the tumor, removing it in en masse technique of tumor resection that we have published. En masse. What do you think?
I'm sorry, what's the en masse?
腫瘍を外から丸ごと取っちゃうってこと。メニンジョマみたいな。
It depends on the case, I think. So, in the case of major temporal lobe, it's very difficult to resect en masse. So, yeah, I try to resect.
Please, me.
So, Arturo, can I comment?
Yes.
I'm a huge fan of all mass resections. I think you get a much better plane between normal tissue and diseased tissue. And I never go inside the tumor with the CUSA and sort of shell it out, because I think you lose all the topography. I personally cannot visualize how much tissue disappears in the CUSA. So I have a hard time knowing, is my tumor collapsing towards where I'm working, the resection cavity, or am I already at the margin? So I like the technique that Dr. Gola has described, going at the surface of the tumor where you get a different texture, a different color. It even sounds different in the suction. Yasha Gil always described the amount of edema in a tumor changes the consistency and the cohesiveness. And therefore, when you use a fine suction, you can hear when edematous tissue disappears, which sounds different from normal white matter. And I think in low-grade gliomas, that is definitely helpful. And then visualizing high-grade gliomas, go around is usually a good way. I think monitoring, as you said, is key, but at the same time, I sometimes do supramaximal resections where I say there's a vessel going into the tumor that supplies the majority, so I take that vessel anyway, so I may as well take everything that's supplied by this vessel, which decreases your postoperative seizure. It's just my take.
So, Dr. Goyle, thank you very much for your very comment. So I think en masse resection is any grade of the glioma. Yes?
Yes, any grade, even high grade, low grade. Another question, I want to ask, because this was a very good lecture on glioma, I want to ask one more question. And even Dr. Kasper I will like to have his opinion. See, sometimes we are doing functional resection, like we are removing the tumor, and we are removing the brain around the tumor. So tumor and around the tumor, that brain. What do you think this tumor around the brain should be removed if it is functionally active, or what? Like Dufau says that you have to remove the brain around the tumor. What is your feeling, whether you should remove the normal brain or not normal brain around the tumor?
So it depends on case, I think. So if it has function, normal brain has function area, we don't reject the area. But for example, right frontal lobe case, maybe we can remove normal brain. It doesn't cause any problem after surgery. I think. So it's a mental case, I think.
Maybe Naka-sensei, you can read the Goyle paper, please.
So I have a strong opinion on that too, Atul. I think I'm in favor of taking the brain around the tumor. I don't do lesionectomies. Whenever you have a chance, let's say temporal lobe, frontal lobe, occipital lobe, and the tumor is growing in the middle and there's a, 2 centimeter margin left on the temporal lobe, the temporal tip is not affected. There's no benefit in leaving the temporal tip behind if you took the middle of the temporal lobe already out, because it's disconnected. It's only an invitation for recurrence. So I think if you can take the lobe, take the lobe. Obviously, that doesn't apply for deep-seated tumors. You have to be much more narrow with your margins. It doesn't apply to eloquent areas, left-sided speech area. You have to be really, really tight. But if you're in an area, parietal lobe, occipital lobe, frontal lobe, right side, temporal lobe, right side, you can definitely take the lobe. And I think it decreases your post-surgical recurrence rate. Give a talk about this. I have a cool talk about this.
Thank you very much. So let us move to the next lecture now.
Yes, we are waiting for that. Okay, family.
So now I would like to invite Professor 𝒂𝒑𝒒𝒊𝒂𝒂 from Thailand to present about how can chronic subdural hemorrhage be managed through alternative treatment options.
And the subdural hemorrhage is not for only bleeding vein tear, but it's involved about the inflammatory process. And because the incidence of chronic subdural hematoma is increasing because the patient have the higher age and has some the condition of the brain atrophy. In this condition has the problem with the condition of the patient who use the anticoagulant and antiplatelet after surgery. This is for risk for rebleeding or the risk for resurgery. Now the principle of treatment we don't know, but we change the strategy to treat regarding to the pathophysiology concept. Is a focus on the inflammatory and angiogenesis factors, and there is no consensus for the treatment because New England Journal have been proposed the dexamethasone to treat this, but now this theory already rejected. But the high impact journals have published about the another treatment strategy, like have some minimally invasive treatment, like embolization with the middle meningeal artery to have a very appreciated outcome. And now a very big series, they conclude to do about meta-analysis and systematic review. And in some papers, they propose about the standalone treatment with embolization compared with the surgery. Which one is more improvement of the treatment outcome? Because subdural hemorrhage have many strategy or many theory like inflammation, angiogenesis, rehemorrhage, or exudation. And the after surgery, the brain needs about the time to re-expansion is a need to about 1 month or 4 weeks. But the recurrent rate from surgery and the burn about 70% and craniotomy is about 30%. It's really high rate or recurrent. But the embolization, we can reduce the rate of recurrent to only 4% because after embolization, brain has re-expansion. And the size is really reduced the subdural hemorrhage by 60% in only 7 days. Because the middle meningeal artery can supply about the only subdural capsule like this. And the leaky capillary network can represent this about the multi-state of chronic subdural hemorrhage like this. So the embolization have the role in the multi-stage of subdural hemorrhage, but the single state may be not effective. However, the middle meningeal artery that is the role to supply the dural artery have anastomosis to many vessels, especially there has anastomosis to ophthalmic artery and the ICA. This is should be concerned before we go on to embolize about this vessel. And also the middle meningeal artery can give the ophthalmic artery. This is a contraindication to embolize in this vessel. For another important role of a middle meningeal artery around the foramen spinosum, it can supply about the facial the pretas band that supply the facial nerve. This is a foramen spinosum. That's a middle meningeal artery is allies and give the band to supply about the dura. So the facial arcade is located around the foramen spinosum. For the safety margin that we can embolize just only distal one, because if we embolize in the lower part of middle meningeal artery, we can cause facial palsy. So I summarize about the complications of the middle meningeal artery. Embolization should be blindness, weakness, or the facial palsies. About the embolic material that we use the contour. That means the particle. And the particle is very easy to find in the market because it can use with together of the microcatheters. I recommend to use the contour the size of more than 100 microns, because the smallest vessel that we can see on the angiogram is above 80 microns. So if we choose the smaller than 80 microns, that means it can go to the very small and go to the anastomosis cause of the complication. How about the advantage of the particle? That means we call the polyvinyl alcohol particle. It's very safety and very friendly user. It's easy to inject. It's not painful. A very short time for embolize and very inexpensive. And many catheters we can use together with the embolization. But in some surgeon or some center use above the liquid embolic material like a glue or onyx. But I think it's very costly and they have very more time to embolize. And the catheters that can use or compatible with this material is very high cost. But I recommend use the market now is available in market. We call the embosphere because the particle is like a spherical shape. So it's very easy to reach to the target, the vessel. And it's very effective and very short time to embolize. And the indication of selective case that we can use the middle meningeal embolization for treat meant about the chronic subdural hemorrhage. The first one we can use standalone, or we can use to adjunct the surgical evacuation. Or for another indication, we can use in the patient have like coexisting to use the anticoagulant that we can use together. Do no need to stop the anticoagulant, and we can use to some patients to have very severe comorbid disease. That means they cannot tolerate for get the surgery. How about the occlusion? Or in some cases, we cannot should treat this treatment. That's one. The first one, the patient has the high increased intracranial pressure. that needs to urgent drainage for the primary treatment. And the second one, we have about the dangerous anatomosis to ophthalmic artery or the intracranial vessel. The protocol to do the embolization, I inject the common carotid artery to study about the size of the external carotid artery, the pattern of the ophthalmic artery, and the pattern of intracranial vessel. For the second protocol, we super selective to the external carotid artery to see about the branch of middle meningeal artery like this. And then we have a log map to select with microcatheter to the distal middle meningeal artery, then inject the contrast to check about the area that supply about the dura, and that is the anatomosis to ophthalmic or not. Then we start embolization. We can see about the signal of embolization. Then we check about the post-embolization. That means the middle angel artery was gone. And check about the complication regarding embolism to the intracranial vessel. So the outcome evaluation I study in the 3 months follow-up. I use the CT scan and check about the complete resolving of the chronic subdural hematoma and the complication like cranial nerve dysfunction or about the length of stay in the hospital. I give the example. This is an 82-year-old male. He have like a AAA disease and treat with the stent EVA for 3 weeks. But the patient on the anticoagulant warfarin, but he present with headache, and we can see the subdural hemorrhage in the left side. At that time, because he has some problem of the critical of intracranial hypertension, then I surgery to do a burr hole. After burr hole, some have a recurrence condition of the same side. I just wait for 2 months or 3 months, but the patient is very fine at the time. But the vascular surgeon asked me to resume the anticoagulant as soon as possible due to the stent at the aorta. So I bring the patient to treat with the embolization at that time with embolization. And there was no complication. And just immediately, I resumed the anticoagulant at the time post embolization. And the follow-up CT scan for 3 months is already gone of the subdural hemorrhage in the left side. How about the first line or standalone treatment with embolization without surgery? I choose to treatment this technique in the asymptomatic patient. My symptom, the elderly patient have the several comorbid disease. In this one, it's a male, 71 years old. He present with dizziness, in some time have a headache, but no weakness, because he is the cost officer, so he would need to do any more for surgery. So I just have talk with him and bring him to treat with by embolization. You can see the angiography, can see about the area of compassion in this one. Then I go up to the microcatheter to the middle meningeal artery, and this is a follow-up 1 month. Can see the remaining of the subdural hemorrhage, but for 2 months, the complete resolve of the subdural hemorrhage. The key clinical condition is really good. This is a 82 years monk. He has minor head trauma. At the time, because he had my weakness, so I just only follow up for nearly 3 months. But the increased size of subdural hemorrhage is still increasing. During the conservative treatment, the patient developed above the pulmonary embolism. This one. So at that time, the pulmonologist start about the anticoagulant. But I think we should not wait for the treatment at the time because the progression of subdural hemorrhage will occur. So I start to MRI at the time of the middle meningeal artery. How about the results? I follow up about for 1.5 months. The hematoma already gone and the patient is really fine. For another case, this one have anticoagulant at the time. She presents about the status epilepticus and headache. You can see in the left side of the subdural hemorrhage. At that time, I start embolization because the patient need to resume about the anticoagulant, and I start the NOAC immediately after embolization. And finally, the subdural hemorrhage is improved, and the patient is no critical condition of seizure or weakness. For another case, this is a female 73-year-old had Alzheimer's disease, have some psychotic problem. He hit her head in many times because she cannot control about the position. You can see the multi-state of the chronic subdural hemorrhage on both sides. Because she is really old, so the relative would not don't need to take her to the operate. So I just treat by embolization, and you can see about the mass effects allowed here because they're from the subdural hemorrhage. After treatment, for 2-month follow-ups, you can see it's smaller size, and finally well brain expansions, and the clinical is improved. For another case, they have subdural hemorrhage in the left side, and they have delayed thinking, and they have some impair about the cognition. After embolization, you see it's very clear. This is VVIP cases. So in my case series, no case of have the complication, and every case after 6 months have no symptom of headache and have a full recovery. For my future study, I think if we have the improve about the imaging, we can find about the arterial network, the anastomosis to contralateral side. So we just only give one attempt to about the capillary network and treat both sides of the chronic subdural hemorrhage. And now they have like a very interesting projects to use the embolization to treat about the epidural hemorrhage. And this treatment can prevent about the expansions of the epidural hemorrhage, and in some surgery use the embolization to treat about the chronic headache, or also to treat about the refractory migraine. So my conclusions, I think that middle meningeal artery embolization have the alternative treatment in the my symptom patient, or in some cases have the recurrent rate of chronic subdural hematomas. It can use standalone, or it can use to adjunct surgical drainage. It has a benefit treatment in the elderly patients, or have some patients have the concomitants of anticoagulant and antiplatelet medications. This one have is a minimal invasive procedure and short time for operation. About the cost, I think it's not too expensive one, and I recommend in some group of the patient it's very effectively. Thank you.
Yeah, that was a very, very interesting and very important subject, and very much discussed subject about the need for embolization in a case of a chronic subdural hematoma. You see, people like us who have been doing chronic subdural hematoma treatment for a long time, we have been doing one burhole, and that's the end of the story for so many years, and we have been very happy with this treatment. And the results are very, very gratifying, and very good results following just one burhole and finish. Now this emergence of this technology and this explanation and this treatment is, of course, emerging one of the most modern kind of treatment in neurosurgery. I will say still we have to be very much guarded about the efficacy of all these things over burhole and over repeat burhole if it recurs and all. But what results have been shown by you, by others, and by recent publication does show that there is a big promise in the treatment by endovascular embolization and various kinds of endovascular glues and all those things. But, to change the treatment completely from one to another, and standalone kind of treatment, as you mentioned, will obviously take some time, at least for people of older generation who have been very comfortable with burhole treatment. What do you say, Yoko? What do you think about this treatment?
Yes, I totally agree with you. Yes, but sometimes the difficult case because of multi-lobulation or some septation cases. So just I would ask Ichi, maybe is it the same procedure if there is some septation case or very sick of the wall? What do you think about? Basically, yes. I totally agree with you, Dr. Goel. Yes.
Yes, Professor, this is a very interesting condition because multi-stage or multi-stage of the chronic subdural hematoma is very, very effective to treat with embolization because the embryonic material can occlude about the capillary network that's supply about the hematoma that have like some bleeding at the time, so the inflammatory cell could not produce about the some cytokine. So the recurrent rate is really low and very effective in some the older patient who has repeated head trauma and use about antiplatelet or anticoagulant is very interesting, Professor.
Thank you so much. Thank you. This is a very excellent talk. Thanks.
Professor Mohan Sama, you have commented?
Yeah, thank you so much. Excellent presentation. In Nepal also, we have been doing this endovascular embolization for chronic subdural. I am very sad to say that we are giving up one more surgical case to interventionist, radiologist. Very sad for neurosurgeon. I think Dr. 𝒕𝒔𝒖𝒓𝒂𝒊 seemed to have done the fellowship himself. So he is a dual trained neurosurgeon. So he retains the case. In our hospital, unfortunately, the cost of this endovascular MME embolization is 5 times higher compared to open borehole. Borehole in our university hospital is equivalent to $150 total cost. So very cheap. Whereas if you do endovascular, it is almost 1500 USD equivalent to. And we talk with the radiologists, what they say is the catheter, disposable catheter, and the PVC, the polyvinyl alcohol, and onyx is very costly. So we are not very enthusiastic about the this new modality. I think some Western countries, the recommendation is after you drain the chronic subdural, you prophylactically do embolization so that the recurrence is low. But we have to take this, new technology with a pinch of salt in our setting. Thank you.
Thank you, Professor.
Professor Asra and Fauzi, could you give some comment on the presentation?
Thank you, Ben. Thank you, Professor Kato and Professor Goel. Yes, in my center, the treatment of chronic subdural hematoma by endovascular treatment is done by my colleagues too. Yeah. So I lead the neurovascular center that treated both kind of procedure, and we have a fellowship too in our country, and we train a dual neurosurgeon who do both open and endovascular treatment. And we also have experience doing this procedure in chronic subdural hematoma, especially for recurrence cases. So I'm very happy that my friend Itichar showing us the indication for first attempt to use endovascular approach in such cases. So thank you, Prof. Itichar. You done good job. Thank you.
Thank you.
Ben,
comment, Ben?
No, so
yes, if I will say one thing that ET has very well shown the beauty of this MMA embo, but the selection of cases are also very important in such cases. When patients are Mark Walder grade 1 or 2, it is good sometimes. But there are other modalities also, like we published the largest series of chronic subdural hematoma treated with tranexamic acid. It is a fibrinolytic agent and antifibrinolytic agent, and it was originally discovered in Japan from Kobe University. So we have had excellent results, and tranexamic acid costs less than $1 compared to $600 of treatment with MMA. I think different areas need different expertise, but in LMICs, I think the choice will be where your economics tally your patient's ability to pay. I think that would be more important.
Yeah, thank you. I have read about this issue that you mentioned before. It's really good result. For the embolization, I want to acknowledge all of you. Now with the microcatheter is now we use the product from Japan, so the cost is not too high compared about the catheter from North America or the European country. So I suggest you, okay, now we can reduce the cost. It's very low, and we can choose about the material to treat it. I think this is the future strategy for treatment is very, very effective. Thank you.
Little Ben, you have
yes,
some...
just a quick just a short question to ET. Yeah, and congratulations to your result, ET. And we know that MRI embolizations seem to be an effective treatment for the chronic subdural. I would like to ask about for your experience. So, if do you also give medical treatment after to prevent the recurrence of chronic subdural after the embolization? For example, with giving 𝑠OCOR or giving the lipid lowering agent or the dexamethasone. do you still give them after your procedure?
Now I do not give about the medicine like this because it's not strong evidence to decrease. That this is important because for 5 or 10 years ago they mentioned about lipid lowering agent or the about some antihypertensive drug or dexamethasone or steroid can reduce about the thickness or the volume of the chronic subdural hemorrhage. But in some patients, they don't have like a comorbid disease like hyperlipidemia or hypertension or have some like easy to infect for some condition. So now I use the embolize alone, do not use any medicine by oral or by pill.
Yes, because sometimes the result may be confounded by these factors during when looking at the literature review. Yes, Fram, you have a comment?
Dr. Ithishai, in my
Yes.
institution in Hanoi, we also do the embolization for some recurrent and also some high risk of recurrence cases as well. There's an idea that appeared in my mind that for the cases with indication for embolization, is it possible for during the surgery we can use the endoscope to the MMA?
You mean for endoscope?
I think it's possible. Yeah, to coagulate with the assistance of endoscope. I know that in some institution and with the septed subdural hematoma, they use endoscope for that kind of hematomas as well. Can we use that to coagulate the MMA with a single burr hole?
Yeah, I think
that's my idea.
Yeah, it's good. It's good because it's we have two actions like to treat about the inflammation process, and another one can like a break about the capsule and release about the pressure. I think the result is really quick. I think it's very excellent if we can do it together. Yes.
Yes.
Thank you for your suggestion. It's very good.
Thank you very much.
Yeah, and Fame, I think I also have this idea, but there's one of the questions that I would like to ask your opinion, and also because sometimes it's not the main tongue of the MMA causing the problem. It's the angiogenesis. So you need to with the embolization, you can target the terminal branches. I mean, you can with the embolic material, you can go into the site of the angiogenesis. They're causing the cancer period. So if using the endoscope coagulating the main trunk, still there will be chance that it gets supplied from the meningeal glands, other meningeal glands that may cause the angiogenesis. That's the question that or the things that I cannot prove myself. Because sometimes when you open the burr hole, we encounter the main trunk of the MMA, and I cauterize it, but still, and sometimes it gets recurrence. So it seems that it comes to my mind that maybe the main trunk will coagulating the main trunk, or you just cut it off, might not help with the situation a lot. So I'm thinking if you're using the endoscope, so I think do you mean you target the main trunk, or you use it for another?
Yes, the main trunk. And I think we can also make a clinical trial on that as well.
Yes, that's an interesting question.
And can I have the expansion from the question of Dr. Ben? This is a good question because now interventionists believe that is we should embry in the capillary base. It's not only the main trunk, because if you can cut the main trunk, but this distal artery have many anastomosis to another band, like they have the frontal band or the STA, superficial temporal artery, or the another trunk. So if you cut or you coagulate only the main trunk, it's not effective to cut up the blood supply to the capsule of the chronic subdural hematoma, especially in the multi-stage or the septation of the subdural hematoma is not can occur also. So embolization only can go through the distal band and can occlude everything. I think this is a very important thing you should consider. Thank you.
Thank you so much.
So we have on the 5 very productive and full of knowledge from the 5 presentations. Now at the end of the webinar today, I would like to invite Professor Artin Cohen and Professor 𝑧�𝒂𝒊 to have some words to close the webinar.
Okay, well, still, are you with us now?
He's on phone, maybe.
On phone. Very easy. So thank you very much. I think the 5 talk was a very, very, very excellent, I think. And also the Goyo and Astra, and also Dr. Raja. So many good commentators give us great suggestion or comments. I think that the research mind is very, very important for especially young doctors. Always think about why, how. It is very important. It's very productive, the webinars today. Thank you very much. What else to say? No,
I enjoyed, Yoko, very much this webinar.
Thank you so much.
There are some nice subjects we discussed, and I think I enjoyed it.
Thanks a lot. Maybe we'll considering about award which you suggested. Yes. Thanks a lot. Yes. Okay, so see you next time. Bye bye.
Bye bye.
Bye bye.
Thank you.
Thank you.
Bye. Thank you.